Hello everyone and welcome to today's Connect and Learn webinar. I'd like to begin by acknowledging the traditional owners of the land on which we meet today and pay my respects to their elders past, present and emerging. I extend that respect to Aboriginal and Torres Strait Islander peoples listening today or in the future. My name's Rebecca and I'll be facilitating today's webinar, which is on working effectively with people with a diagnosis of BPD. This webinar is a part of a series of Connect and Learn webinars designed to support AOD clinicians throughout Victoria, but we acknowledge that we've got a number of people interstate and perhaps globally. The webinar series is funded by the Victorian Department of Health and hosted by Turning Point. We hope to make this as interactive as possible. Please ask questions along the way using the Q&A function, not the chat function. The questions will be collated and answered by our presenter at the end. Please be aware that our webinars are recorded and are later made available on the Turning Point website. We encourage you to stay to the end of the webinar and complete the exit survey. It'll appear as a QR code on the final slide. It'll also be emailed to you later today. Our presenter has kindly agreed to provide a copy of the slides, so please enjoy the webinar. There'll be no need to take notes throughout. I'd like to introduce our presenter, Associate Professor Sathya Rao, who is a psychiatrist and the Executive Clinical Director of Spectrum Personality Disorder Service. He is the Vice President of the Australian BPD Foundation. He is also an Adjunct Clinical Associate Professor at Monash University. Sathya, thank you so much for joining us today and for speaking to us.
So thank you, Rebecca, and good afternoon, everybody. Can you all hear me and see the slides properly?
Yes, perfect.
Perfect, thank you. As Rebecca mentioned, I will talk to you briefly about how to work with people with a diagnosis of borderline personality disorder. I will provide a brief update and highlight some of the treatment principles and briefly touch upon how to refer people with borderline personality disorder to Spectrum. As all of you know, borderline personality disorder is an extremely common condition. It impacts at least 1% of the community. Contrary to what was previously believed, we now know that borderline personality disorder impacts both genders equally. Although in the clinical populations, we see women presenting with borderline personality disorder predominantly. My guess is that often men with borderline personality disorder would present to drug and alcohol settings and in some difficult circumstances in justice systems. Unfortunately, the stigma and discrimination is rampant in borderline personality disorder. That's by and large because still people don't understand the condition adequately, and people subscribe to some of the older views about borderline personality disorder. Borderline personality disorder usually emerges during adolescence. We can diagnose borderline personality disorder from the age of 12. That is according to our own national guidelines. And of course, we are looking at post-puberty. Still, there's a lot of resistance to diagnosing borderline personality disorder earlier on. As a result, treatment gets delayed. Borderline personality disorder can present across life stages. And there is some research to show that late manifestation of borderline personality disorder can happen. We have done some research and shown at Spectrum that BPD can be diagnosed after 64 years of age. We've in fact treated people in their 70s and 80s for a diagnosis of borderline personality disorder and successfully so. How to recognize borderline personality disorder? Usually people with borderline personality disorder present with a history of trauma. It is not a prerequisite, but it is common. And people with BPD tend to injure themselves repeatedly. Uh, the common way of a self-injury is cutting. They also experience suicidal thoughts for several years, and they present with unstable uh, mood symptoms, difficulties in interpersonal relationships, and difficulty in understanding who they are, the self identity. Impulsivity is another common symptoms, and anger outbursts, and also a very painful feeling of emptiness, the nothingness which they experience. It is an important psychological symptom as it can be very painful. They also experience fear of abandonment in interpersonal relationships and have difficulty forming trust. And some of them can experience repeated dissociations and, for short periods of time, the psychotic like symptoms. Of course, not all the symptoms are going to be present in the same person. People can have different permutations and combinations of these symptoms. Borderline personality disorder almost always co-occurs with several other psychiatric disorders. I would like to just highlight a couple of them. Polycystic ovarian syndrome, which is less well known as a co-occurring condition, that can occur in people with BPD in about 25% of cases. Chronic pain, I'm talking about physical pain, again is quite common in borderline personality disorder, and it occurs in about 30% of people. Of course, we know that substance use is extremely common. Two-thirds of the people with borderline personality disorder can experience substance use, and substance use usually goes down once their primary condition, which is borderline personality disorder, is treated. Now, there's a lot of controversy about the etiology or the cause for borderline personality disorder. I'll quickly summarize what is currently known. We now know that half of the reason why people develop borderline personality disorder is because of genetics. So there's a 50% heritability. We know that the emotional part of the brain, the amygdala, is hyperactive, which would explain why people with BPD experience significant emotions. Also, the control mechanisms for the emotions, which is the part of the brain called the cortex, and there is very poor cortical control over amygdala, which means the emotions are running wild and the control mechanisms are very limited or poor in BPD. We also know that the part of the brain which is involved in trust and cooperation can also be abnormal in BPD, namely the anterior insula. So, there's a lot of literature to talk about trauma. Sometimes people misunderstand that childhood trauma equals borderline personality disorder. Uh, there's a slightly, we now have a much more nuanced understanding of the relationship between trauma and borderline personality disorder. Trauma is a very significant risk factor for BPD, although not causally linked. What it means is that not everyone who has experienced childhood trauma will develop borderline personality disorder. Sexual abuse is common, disorganized attachment styles are common, and neglect and invalidating developmental experiences is also seen often. So, biological and psychological factors are causal, with each person having a unique pathway to developing borderline personality disorder. However, to what extent the biological factors or the psychological factors play a role in causing borderline personality disorder, uh, there is a bit of a dispute, and the relative contributions can be different in different situations. So the whole debate of nature versus nurture is currently outdated. We now need to consider nature and nurture, nature via nurture, or nurture via nature. So as you can see, it is much more complex. But what is important to recognize is that having borderline personality disorder is not the person's own fault. It is a disorder of the brain and the mind. This is a very important slide because often it is misunderstood that people with BPD have control over what they can do, and they're not exerting that control adequately, which is not true. Borderline personality disorder is also associated with significant mortality and morbidity. The suicide rate is quite significant, 10%. And the lifespan of a person with borderline personality disorder is reduced by 20 years uh, because of other medical causes. We know that the suicide rate can go up by multiple folds if a person with borderline personality disorder also uses substances. We at Spectrum have done an investigation using the Victorian coronial data. What we find is that 99% of those people, of the people who have died by suicide with a diagnosis of borderline personality disorder, have gone through public mental services in the preceding 1 year. And 88% of them have made contact in the preceding 6 weeks. And a quarter of them have been to emergency department 6 weeks prior to death. So what it tells us is that people are actually contacting services and seeking help. We now need to make sure that during those contacts, everybody is screened adequately and whether we can initiate suicide prevention strategies. So this is another slide from the same study to show how people are making significant contacts with multiple health professionals and services prior to death. We also looked at some of the data from the emergency department, and what we know is that people with BPD are more likely to present to emergency department via ambulance, and a small percentage of them attend multiple times. In our study, 21% of the patients attended between 20 to 100 times. And a small number of patients, 23 patients in our study, attended emergency department more than 100 times. I don't expect you to go through see the list and read the list of treatments mentioned here. So specialist treatments, this is a list of all the specialist treatments that are evidence-based, that are available for use. And these are a couple of Australian contributions, the conversation model and the acceptance and commitment therapy model. All of the specialist treatments for borderline personality disorder are equally effective. There's nothing much to choose between DBT or MBT or schema-focused therapy or transference-focused psychotherapy. All of them are equally effective. No one treatment is superior to another. And there are more commonalities than differences between all of these treatments. This is a list of all the generalist treatments. Generalist treatments such as structured clinical management, general psychiatric management, good clinical care, supportive psychotherapy, integrated treatment. These are all manualized evidence-based treatments which are general in nature. And what we find that they're also equally effective. And what we know further is that generalist treatments are as effective as specialist treatments, and they're equally effective. And there are more commonalities than differences between specialist and generalist treatments and each other. Really, what it tells us in summary is that there's nothing much to choose when it comes to efficacy, because all of these treatments are going to work. As long as we can pick one of them and use it, they're going to work. There is further research that has happened looking at the specialist and generalist treatments and looking for the common ingredients in all of them. And so there's research into common ingredients of specialist treatments, generalist treatments, and some of it was captured in the NHMRC Clinical Practice Guidelines, which was published in 2012 for BPD. And also the international expert opinion has been taken into consideration. And looking at a list of all these common factors. And we know that common factors work and the generalist treatments work because when mentalization-based treatment was compared with the structural clinical management, which is a generalist treatment, and a follow-up study was done for 8 years, the benefits were maintained both for a mentalization-based treatment and the structural clinical management at 8 years of follow-up. So we know that it works, generalist treatments work, and also even in the long term, it helps to keep the benefits. So our NHMRC guidelines, as I was mentioning earlier, outlines general principles for treatment that are similar to the common factors of specialist and generalist treatments. In fact, the NHMRC guidelines do not recommend a specific specialist treatment. Spectrum experience, our experience is that for most of our patients, if they receive 1 to 2 years of group and or individual psychological treatment, this seems to result in significant remission and recovery for the most complex, most unwell borderline patients in the state of Victoria. As you would know, one of the referral criteria for borderline personality disorder is that they've reached the end of severity and complexity. So this is one of the study which we're just about to publish that shows that 86% of our patients achieve clinical remission after 18 months of psychological treatment. We have published a 12-month outcome data for the spectrum group treatment, which again improves clinical outcomes, improves quality of life, as well as reduces self-injury acts and suicide attempts. We have done a follow-up study for 18 months, which again shows significant improvements and maintenance of the benefits at 18 months. We have also looked at another model, which is a 10-week intensive group treatment for borderline personality disorder based on the common factors. So what it means is that we provide 80 hours of group treatment, which is 8 hours of group treatment a week for 10 weeks. And that study again shows significant reductions in self-injury and suicidal behaviors, even in 10 weeks. These are a couple of international outcome studies. These are the two landmark studies. One is the McLean study, the other one is the Eclipse study. In fact, the McLean study has gone on to 26 years of follow-up now. And what it shows is that most people with borderline personality disorder achieve symptomatic remission, and some of them can recover. And very few people with borderline personality disorder require lifelong treatments. So therefore, we must give up our therapeutic nihilism and replace it with realistic hope and optimism. Because we now have effective treatments for people with borderline personality disorder, and almost all of these treatments work. So, what's the prognosis with the specialist treatments? And for example, mentalization-based treatment, the 60% remission rate at the end of 1 year. General psychiatric management, 65% remission by the end of 2 years. DBT, again, 60 to 80% remission by the end of 1 year. So these treatments work. So there's a summary of outcome of all the outcome studies. About 10% remission rate within 6 months, quarter of them within 1 year, half of them in 2 years, 85% remission in 10 years, and 60% of the people can recover in 16 years of time. Recovery meaning having meaningful relationships as well as holding on to gainful employment. Look at the relapse rate. Relapse rates are extremely small for borderline personality disorder, only 15%. Compare that with depression. In depression, there is a 50% relapse rate. So therefore, BPD is not an enduring disorder. Let's look at the self-injury and suicide attempts. Again, it goes down quite significantly over a period of time. Compared to the baseline, which is 70%, look at 10 years, only 5%. With treatment, of course. So when we look at the spectrum data for death by suicide, We have lost 12 souls out of 4,000 patients in treatment at Spectrum over the last 25 years while they're in treatment. Again, I don't believe we have any superior psychotherapy skills or some superior skills to manage risk. We have the privilege to work with people with borderline personality disorder with psychological treatments for 18 months to 24 months. I think that's what makes a difference. We have done some attempt at the follow-up, and our follow-up data shows that only 2% of the people die by suicide, even at follow-up. So, in summary, when people with borderline personality disorder are treated, suicide risk goes away. Let's look at some of the biological treatment options. Unfortunately, there are no medicines that are patented or indicated for borderline personality disorder. So, to this day, we don't have any medicines that works for borderline personality disorder, period. And what's worse, we know that a quarter of the patients with BPD attempt suicide, not self-injury, suicide with prescribed medications. So we need to be really careful while we prescribing medications. There's some very limited evidence for lamotrigine, torpidamide, omega-3 fatty acids for treatment of BPD, and quatipine can be used in small doses for crisis management. Again, the data is limited. We did an audit in Victoria, and we found that 50% of the patients were prescribed 3 to 5 psychotropic medications simultaneously. Looking at electroconvulsive therapy and transcranial magnetic stimulation, again, there is no evidence that they work for people with borderline personality disorder, even when BPD co-occurs with depression. There are a couple of papers which are published saying that they may have some beneficial effects, especially TMS, but data is not robust or convincing. TMS, there is a little more promise, but needs more research. At this stage, TMS, one should conclude that there is no place for TMS or ACT in the treatment of BPD, even if there is co-occurring major depression. However, we know that if you treat borderline personality disorder with major depression using psychological treatments, not only borderline personality disorder goes into remission, the depression also goes into remission. So there are several guidelines for treating borderline personality disorder throughout the world. We have the British guidelines, Australian guidelines, several of the European guidelines, and also guidelines published by our New South Wales colleagues. Now, if you look at the summary of all those guidelines, this is my take on the summary of all of this slide. We need to help people with borderline personality disorder get well. For that, we require psychological treatments. We need to help to keep them alive because they have repeated suicide crises. So we need a good crisis intervention. We need to help people with borderline personality disorder improve their physical health and well-being. Remember, I told you earlier on that when just because of having a diagnosis of borderline personality disorder, there may be a 20-year reduction in the lifespan of a person. So we need to attend to the physical health. We also need to help people with borderline personality disorder improve their quality of life, jobs and relationships, and we need to support and educate families and carers. Now, this is a summary of the treatment principles, which is a distillation of all the evidence-based approaches. Remember the specialist treatments and the generalist treatments, as well as all the guidelines. This is my summary of all the treatment principles from all of them. Let me just quickly go through them. First of all, we need to establish a clear diagnosis of borderline personality disorder using DSM or ICD-11. And once we diagnose, we need to commence treatment as early as possible, even from the age of 12, if it is diagnosed at the age of 12. We also need to identify and manage any co-occurring disorders. We need to provide psychoeducation to patient and family and carers. We need to develop a shared understanding of the condition to help people with borderline personality disorder make sense of themselves and also how they can embark on the recovery journey. Often people with borderline personality disorder would be blaming themselves because they don't understand, they may not have understood that it's a disorder that makes them behave and think and feel the way they do. Where possible, we should provide access to BPD specific psychological treatments. So this is one of the guidelines presented by one of our colleagues in Harvard, um, talking about the management of comorbid conditions. So when people have a co-occurring bipolar 1, a mania, or with a severe substance use disorder, or a severe anorexia, these are the conditions where you have to treat those conditions first before you treat borderline personality disorder. In other conditions, you could treat borderline personality disorder simultaneously, or in fact, when there is mood disorders, bulimia nervosa, and anxiety disorders, narcissistic personality disorder, you want to prioritize treatment of borderline personality disorder. Okay, going on to other treatment principles, we need to have a thoughtful management of crisis, develop a crisis plan, which is collaboratively developed uh, with our clients and family members, and particularly noting how to work with societal self-injury behaviors. We always need to keep the recovery focus, keep an eye on the jobs and relationships. We know that jobs and relationships also improve the outcomes for people with borderline personality disorder. There's a list of all the psychological treatment principles. It needs to be evidence-based. Psychological treatments need to be structured. They need to be consistency. We need to have compassionate boundaries and flexible limits. It needs to be trauma-informed. We need to have pragmatic interventions. Keep an eye on the therapeutic relationship, which is very, very important, and keep a focus on emotions of the patients, as well as the emotions that we as clinicians can experience while working with people with borderline personality disorder. We also need to keep the focus on here and now matters using mindfulness and develop, again, collaborative treatment plans involving family and carers and all relevant stakeholders. We need to help develop skills in our clients to manage the painful thoughts, emotions, self-sabotaging behaviors at times, suicidal and self-harming behaviors, and interpersonal challenges. We need to use medicines extremely sparingly, uh, if at all, and use hospitalizations again only in extraordinary circumstances. We need to monitor the progress closely because we want the patients to be improving. If they're not improving, we want to be able to review and change and deliver holistic care looking at the physical health and comorbid conditions. And clinicians and patients both need to practice self-reflection, which is processing thoughts, emotions, and reactions, and provide continuity of care and improve quality of life. All these principles, I'm sure they are quite simple and straightforward. I'm sure all of you are already aware of those principles, but the difficulty is going to be in applying these principles in practice. Often, the clinicians' own emotions, biases, and their own preformed thoughts and feelings can come in the way. So that's why self-reflection is very important. So we at Spectrum collaborated with the Australian Borderline Personality Disorder Foundation and the National Mental Health Commission, and the Australian BPD Borderline Personality Disorder Foundation received a significant grant, run a national training strategy. So through the process, Spectrum has, in conjunction with the consumers and carers and the BPD Foundation, conceptualized a core competency training framework using the common factors that are present in all specialist and generalist treatments. And we have developed a training framework, and we have gone around the country and provided training. We've also developed a 10 session and a 20 session brief psychological treatment using, again, common factors approach, and it is available for free download from our Spectrum website. Um, that is something which we recommend that it is used in the primary care setting and in private psychology space. Let's spend a couple of minutes talking about the access to Spectrum programs. So Spectrum provides clinical services, training, and we undertake research innovation as well as advocacy work. We provide consultations to primary sector to some extent. We provide extensive consultations to public mental services. We provide psychological treatments in the form of dialectical behavior therapy, mentalization-based treatment, and acceptance and commitment therapy. We also have a complex care services to service our clients who may have complex needs, and where we have taken a much more flexible approach. We provide education and training. We train about 6,000 to 7,000 clinicians every year, and we undertake research and we innovate treatments. We also provide some services to other states in Australia. Access to Spectrum programs can be difficult because we are a very small service. We are primarily funded to work with people who are already clients of public mental services in the state of Victoria. And our capacity is to treat about 100 to 150 patients every year and provide secondary consultations to about 500 people every year. As you can imagine, that's just a drop in the ocean. So the primary way of accessing Spectrum programs is via the public mental services. So one needs to be a registered client of the public mental health, one of the public mental services in Victoria, and then we need to get the public mental services to refer the patients to Spectrum. So our usual intake criteria for psychotherapy is that they're registered in the public mental health. So by default, because we have such a small reserve and significant expertise in working with people with borderline personality disorder, our clients happen to be generally those who have very highly severe illnesses and have complex needs and are often at very high risk for self-injury and suicide. We also provide second opinions for some of our colleagues in the private sector. This is for psychiatrists. If there are psychologists, they may wish to access this via their treating psychiatrists of the clients or through GPs. We provide some diagnostic assessments for GPs, limited resource, and we provide also education to training to the non-governmental organizations. So looking at Spectrum clients, age of onset of borderline personality disorder symptoms in our client group is usually 14 years of age. That's when they seem to manifest symptoms. But for the next 4 years, they have not got a diagnosis, and they first access the mental services at the age of 18. And the first diagnosis, formal diagnosis, given at the age of 28. So although they start having symptoms at 14, the diagnosis was given only at the age of 28, 14 years later. The time to diagnosis 14 years later. But once they receive a diagnosis, access to treatment is much quicker, especially with their Spectrum clients. Within 1 to 1.5 years, they get the evidence-based treatments. So my take-home message is that any reasonable treatment provided by reasonable clinicians in a reasonable manner may be beneficial to people with borderline personality disorder. So as long as you don't judge, as long as you try to validate the valid, there is always something to validate. And as long as you can tolerate emotions, both your own emotions as a clinician and the client's emotions, and teach them skills to improve their quality of life, you can contribute to the recovery journey. So give it a go. Thank you.
Thank you so much. Sathya, I've got a number of questions for you, and apologies to everyone that I'm sure we're not going to get through all of them. Can you please elaborate why more women are diagnosed than men?
Okay. See, often there is science to say that women often seek help from services, and men often don't do that commonly. That's one reason. Second is, for a long time, borderline personality disorder was thought to be a disorder that impacted only women. That's a wrong thing, but that is how it was. That is what was believed for a long time. But the community prevalence studies clearly show that both men and women are equally represented in the community. Also, men with borderline personality disorder, remember, anger, discontrol, and impulsivity are some of the symptoms of BPD. With anger discontrol, often men tend to attract the attention of justice systems, uh, as well as if there's a co-occurring substance use disorder, they end up in drug and alcohol settings rather than at spectrum.
Thank you so much. Does Spectrum work with men diagnosed with BPD who also perpetrate family violence?
There's probably two different issues. Number one, see if they do have a borderline personality disorder, which is a lifelong disorder, which starts very early on in the age, we would make a diagnosis of borderline personality disorder. And the second part, we are aware that as we don't have much data about men with borderline personality disorder involved in family violence situation. But however, my guess is that it would be very high, perhaps. Um, we know that about 45% of the women with the diagnosis of borderline personality disorder live in domestically challenging circumstances.
Thank you. Are there any apps or new technology using AI that has been effective in supporting people with BPD?
That's a very interesting question. I've been quite interested in the application of AI. My belief is that we will be able to have online treatments, perhaps moderated by AI, which will probably increase the access to evidence-based treatments quite significantly. Uh, Maybe in the next few years, we would see that happen. And clinicians might be able to augment whatever else that needs to be augmented apart from what the AI can offer. I'm very optimistic that that will happen very soon. Of course, there are plenty of apps now available for dialectical behavior therapy, for self-monitoring, the self-harm and suicidal thoughts. There are some apps available for mindfulness, also some apps for which will assist in self-reflection.
Thank you. What is the differential diagnosis of BPD from premenstrual dysphoric disorder symptoms?
Again, so these two are entirely two different conditions. So when someone have premenstrual syndromes, they can have emotional instability, they can have anger difficulties, they can have impulsivity, but they may not have the entire syndrome of borderline personality disorder. So to make a diagnosis of borderline personality disorder, let's say according to DSM, we have 9 criteria which are listed. One needs to have at least 5 out of 9 criteria for a period of time to qualify for a diagnosis. That does not happen in premenstrual syndrome.
Okay, thank you. Has it recently changed that DBT is not the most effective treatment?
No, not at all. See, DBT is an extremely effective treatment. What we are coming to know is that so is MBT, mentalization-based treatment. So is schema-focused therapy. So is transverse-focused psychotherapy. So we know that DBT is very effective. We have now come to know that all the other treatments are also as good as DBT. And what's more, uh, there are factors which are common to all of the treatments, and these common factors are much more easier to learn and to deliver for vast majority of the clinicians. To learn DBT, for example, it takes years, and it is a very expensive treatment. So it can cost up to $25,000 to have the full course of DBT. Whereas common factors approach, which is as effective as DBT perhaps, are much more cheaper to deliver and easier for clinicians to learn and easier for consumers to access. So if we are looking at making treatments accessible to every single person with a diagnosis of borderline personality disorder, uh, DBT might not be the best approach, although it is as evidence-based as anything else. Thank you.
Thank you. How often is autism an underlying factor in people with BPD who are less responsive to specialist therapies?
You see, that's a good question. So we are now trying to understand the co-occurrence of autism as well as uh, ADHD and other neurodiverse disorders. The research is still not significant in this area. In fact, one of our psychiatrists at Spectrum is interested in doing some research in this area. So autism and borderline personality disorder can coexist, and also autism and ADHD can coexist. And when these conditions co-occur, we need to give attention to both the disorders. One needs to be careful not to misunderstand some of the symptoms of autism as BPD symptoms, because there is some overlap between the symptoms.
Thank you. Would eye movement desensitization reprocessing, EMDR, also be considered a possible therapy or treatment for BPD?
Again, that's a good question. Now, EMDR has not been shown to be effective uh, primarily in the treatment of borderline personality disorder, right? However, now complex post-traumatic stress disorder, complex PTSD, is quite common in borderline personality disorder. So people with borderline personality disorder, 50% of them, half of them will also have a co-occurring complex PTSD diagnosis. Now, for complex PTSD diagnosis, EMDR can help. And there's of course, it needs to be done by experienced hands in the context of other psychological treatments. So therefore, in that sense, half of the people with borderline personality disorder, when they have co-occurring complex PTSD, may become candidates for EMDR.
Thank you. That actually fits nicely with the next two questions. Does Spectrum view BPD and complex post-traumatic stress disorder in a similar way?
Look, let me answer what the science tells us. Now, science-wise, we know that complex PTSD and borderline personality disorder are two different conditions. Now, you would be aware that in the latest ICD-11 classification system, that is the International Classification of Disease Classification System by the WHO, that has published in its book that you can make a diagnosis of a personality disorder and or complex post-traumatic stress disorder. In that classification system, complex PTSD and borderline personality disorder are two different disorders. Now, so that is the classification system. Now, what happens in real life? If you look at our patient population, because we are a service that caters to people who have complex needs and highly unwell, my guess is that nearly 75% of our patients would qualify for complex PTSD in addition to borderline personality disorder. Now, see, the science of complex PTSD and borderline personality disorder and whether there are differences, whether they're the same, there's a lot of controversies still. So science-wise, this is where what I said is what stands. Now, just to try and differentiate between the two. So to make a diagnosis of complex PTSD, trauma presence of trauma is a must. Without trauma, you can't make a diagnosis of complex PTSD.
Mhm.
Also, to make a diagnosis of complex PTSD, one should qualify for PTSD in the first instance. So they should have a full diagnosis of PTSD plus three other symptoms, three other features, which are emotional instability, interpersonal difficulties, as well as difficulties in self-identity, usually very severe self-loathing. In complex PTSD, suicidal behaviors and self-injury behaviors are not prominent. Interpersonal difficulties are in the form of social isolation rather than instability of uh, interpersonal relationships. So this is what is in complex PTSD. And borderline personality disorder, I've already explained to you. As you can see, these three symptoms, the interpersonal difficulties, emotion instability, and identity problems, these three are common to both borderline personality disorder and complex PTSD. So there are a lot of overlaps between the two. So as of now, what the science would tell us is that these two are different disorders.
Mhm.
And you need to treat both.
Thank you. Now, this next question is very specific. What options are there for someone diagnosed with BPD, complex post-traumatic stress disorder, body dysmorphia, and major depression with suicide ideation, who is not under the care of a psychiatrist regularly and who wants to help improve their quality of life? This person has said they're having real trouble.
Look, I would suggest as a first step to persuade them to see the GP and persuade the GP to request Spectrum for a one-off assessment. And I mean, of course, there's a wait list and things like that. But if the GP makes a call and requests Spectrum for a one-off assessment and advice, one of the experienced psychiatrists at Spectrum would be able to advise what is the best way to go about accessing treatments in Victoria. So that's probably the first step I would suggest. Ideally, this person should be receiving treatments from services such as Spectrum. And to do that, whatever I told you is probably the first step to access. So I would think that this person would require significant psychological treatments for at least 2 to 3 years of time, and provided by clinicians who are ideally psychotherapists. It can be psychologists or psychiatrists or any other clinicians who are well trained and experienced and who have a background and experience in trauma treatments as well as borderline personality disorder treatments. I would think that if such treatments are provided, the prognosis should be optimistic.
Thank you so much. Can you please speak to BPD and eating disorders as comorbidities?
Yeah. Eating disorders are very common in borderline personality disorder. Now, eating disorder, unspecified eating disorders can occur in more than half of the patients. And bulimia nervosa is again very common. And anorexia nervosa also can co-occur in a small percentage of patients. Now, bulimia nervosa as well as unspecified eating disorders generally respond quite well to borderline personality disorder treatments. So if you have a person with borderline personality disorder and bulimia nervosa or unspecified eating disorders, and if you treat borderline personality disorder, not only the borderline personality disorder will go into remission, but also the eating disorder, which is bulimia or unspecified eating disorder, would go into remission. So there, the prognosis is quite good. Now, when it comes to anorexia nervosa and borderline personality disorder, one would recommend that both the conditions are treated simultaneously. Unfortunately, what we see is that because to do treatments for borderline personality disorder with severe anorexia nervosa, so borderline personality disorder treatment cannot occur if a person is person's physical health is severely compromised. So they need to access treatments for anorexia nervosa first and get themselves medically stabilized, and then access BPD treatments. In the ideal world, I would recommend that both BPD, both clinicians who are working with BPD and clinicians who are working with anorexia nervosa work together jointly and simultaneously to get the best outcome for a person who has anorexia nervosa as well as borderline personality.
Thank you. Under which circumstances would you diagnose someone below age 18? Generally, clinicians seem to be hesitant to diagnose anyone below age 18, and I wasn't aware that it could be diagnosed as early as 12.
Yeah. Look, our national guidelines, the NHMRC Clinical Practice Guidelines for Management of Borderline Personality Disorder, which was published more than 10 years ago, 2012, it was published. And that clearly recommends that we can make a diagnosis of borderline personality disorder from the age of 12, post puberty, and start treatments as early as possible. In fact, our colleagues in um, in the Melbourne Health, Andrew Channon from Origin, have done some significant work in this area, and they have pioneered early detection and early treatment. Unfortunately, clinicians still have still believe in the old concept. See, olden days we used to think that you cannot make a diagnosis of personality disorder before the age of 18. And we thought magically, once they turn 18, their personality is fully developed, and therefore we can make a diagnosis of borderline personality disorder after 18 years of age. So what used to happen is that although people used to have all the signs and symptoms and the clinical syndrome of BPD before the age of 18, we used to not make a diagnosis, and therefore we used to not treat. So by the age of 18, the disorder becomes much more severe. The patterns of thinking, feeling, and behaviors become more entrenched, and becomes more difficult for the person. So there is good evidence to believe that and support that we need to detect BPD as early as possible, as soon as it manifests, and start treatments. Now, how do you diagnose before the age of 12? So you again go back to the diagnostic criteria. If someone qualifies for all the criteria, as we discussed, 5 out of 9 criteria at least, you start making a diagnosis and start treatment. In fact, our colleagues from Origin would say that you don't even have to wait for all of the 5 criteria to be established. Even if there are three symptoms or fewer symptoms, we don't need to start working and start helping the person.
Thank you so much. Sathya, you mentioned early in your presentation that it's not considered an enduring disorder. Are you able to speak a little bit more to that?
Yeah, what I mean by not an enduring disorder is that, say, previously, again, it's an old belief. Previously, people believed that people with personality disorders can never recover, can never go into remission. Those symptoms are going to exist forever and ever and ever. That is why people used to feel very hopeless about the diagnosis, hopeless about the treatment, and to the extent that people would not even make a diagnosis because they thought that we are giving a bad diagnosis and the bad prognosis to the clients, which again has been shown to be a myth. It has been debunked, and we now know that people with borderline personality disorder, a significant number of them can go into remission. Remission is the norm, not the exception. See, I showed you data saying that even at spectrum, where people with most complex needs, high severity illnesses, access treatments, and in our hands, the remission rate is 84%. Now, also, I showed you a 10-year follow-up study which shows that 60% of them can actually recover, not just going to remission, recover. So what it tells us is that if just because one gets a diagnosis of borderline personality disorder, it doesn't mean to say that they're going to live with the diagnosis forever and ever and ever. That's not true. So it's a condition one can experience, and if they get treatments, they can go into remission and recover. So that's what it means by, that's what I meant by saying that BPD is not an enduring disorder and it is not a lifelong condition.
Thank you so much. Can BPD develop without trauma?
Yes, borderline personality disorder can develop without trauma. There is one study which has shown that 29% of the people reported no trauma, but still develop borderline personality disorder. Remember, borderline personality disorder can develop. Remember, I showed you slides saying that there are biological factors as well as psychological factors and social factors. And in some situations, the biological factors might be more stronger, which can make the person develop borderline personality disorder even without trauma. But most commonly, we see a combination of biological factors and psychological factors. Attachment difficulties. Let's say the mother had a postnatal depression and could not bond adequately during very early years of infancy. That can lead to attachment disorders, which can become a risk factor for developing borderline personality disorder.
Thank you, Sathya. I'm just aware of the time. We've got many questions that won't be able to be answered, unfortunately. There's been a number of questions around referral to Spectrum. So I'm just wondering if we can perhaps end with that. Do Spectrum accept forensic clients?
Yeah, see, we consider forensic care as one of the Victorian public mental services, and they are within the scope of referral to Spectrum. And we do work with people in the forensic system. Now, see, access to Spectrum, Now, if you look at the prevalence rate for borderline personality disorder, I mentioned that it is 1% at least. And if you take that number and extrapolate to the Victorian population, approximately 6 million, we would have at least 60,000 people with a diagnosis of borderline personality disorder in Victoria alone. Now, my estimate is that only about 4,000 to 5,000 of those people get evidence-based treatments. So access is very limited. So therefore, vast majority of the people with borderline personality disorder are likely to go without evidence-based treatments. Now, therefore, and Spectrum caters to 100 people. So that is why it's so difficult to get into Spectrum. However, we can help our colleagues in public mental services to treat people with borderline personality disorder effectively. So your first port of call would be GP, and to get referred to the nearest public mental services and get the public mental services to refer patients to Spectrum if they meet the criteria of severity and complexity and high needs.
Thank you. There's lots of commentary around, trouble accessing services. Do you know approximately how long the wait list is at Spectrum?
See, it depends upon, again, the severity, complexity, and the needs. If the needs of the person is very high and complex and risks are involved, the public mental services will escalate the referral and we can respond quite promptly. So we do have a complex care service where the person would be taken up for treatments. For dialectical behavior therapy, mentalization-based treatments, and these two are treatments where we have limited spots. So the waiting time can vary from time to time, anywhere from few months to a maximum of a year. We have done a significant amount of advocacy. We brought it to the attention of the Royal Commission, and we have also advocated with the Department of Health about the care needs of people with borderline personality disorder in the community. We are acutely aware and painfully aware that it's very difficult to access Spectrum. That's because we have very limited spots. So we are very keen to expand our services so that we can reach out to as many people as possible. and help our colleagues in public mental services and in the private sector and the primary sector so that treatments can occur locally and regionally.
Thank you so much. And Sathya, just one final question. Do you provide any services whatsoever to interstate organisations?
We do. It's for a fee-based, we provide fee-based services. We have, in fact, last couple of years, we have provided some care in terms of secondary consultation, occasional treatment and training, and diagnostic clarifications, second opinions, etc., to almost every state and territory in Australia.
Thank you so much. And thank you so much for your time. And apologies to everyone that didn't get your question answered. We will be emailing Sathya's presentation, his PowerPoint, and the video will be available on the Turning Point website shortly. Thanks so much.
Thank you. Have a nice day.